we will have 5 more minutes for these sessions. So we may have 2 questions for one for each presentations. So for the first presentation about the anterolateral distal tibial locking plate, any question from the floor? So I just have one question. So you said that the mismatch that you find is on the diaphyseal segment, right? After the 7th hole of the plate, the plate is off the bone. And did you find the mismatch at the periarticular area of the plate that have the curve at the distal tibia? Did you find any mismatch about the Asian population?
For the answer, at the periarticular zone, or we call the transition zone, at that area we didn't take into the measurement because it's like the transition curve, and it's very difficult to measure the distance, the angle, and so we skip this part because we cannot change anything about this part, because firstly we fix the distal part at a fixed point, because we have 2 variable factors, so we have to fix one factor first, and after that we measure on the proximal part.
Thank you for your answer. Because we still have the problem about the prominence of the plate at the periarticular area, also at the distal femur.
Okay, thank you.
Thank you.
So for the second presentation about the hip fracture surgery using the stocking. So anyone have a questions about these presentations?
I have one question. Do you have the stocking on 2 sides, 2 legs, or only 1 leg?
We apply only 1 leg, contralateral, the fracture site.
Oh, okay.
So and how can you control the dose of the spinal anesthesia that might affect on the hypotension of the patient?
Actually, we use randomized control trial for control, but in specific case, we cannot adjust up to anesthesis.
So it depends on the anesthesiologist's preference?
Yes, that's right.
So that might have the confounding the effect on the hypotension, because the spinal anesthesia might have the big dose can cause the hypotension of the patient intraoperatively and postoperatively. So, and any question from the floor for the second presentation?
Okay, thank you so much.
Thank you.
And for Dr. Yanin for the third and fourth presentations, any question for the presentation about the far cortical locking and the modified RCOST score?
Have any question from the floor?
So I have one question for the far cortical locking construct. You include all of the distal femoral fractures except for the type B fracture, right?
Yes.
So, and do you think any effect on the simple fracture like A-type fracture using the far cortical construct and the standard locking plate construct?
So this study is retrospective study, so I include just only the construct that use like bridging techniques. And I selected just only minimal invasive techniques. That's open incision distally and proximally. And I included the simple fracture that's complete with the screws based on the mechanics of this study to compare, to make it the same comparison.
So you also exclude the simple fractures, but you just only for the bridging technique?
Yes.
Okay. Okay. Don't have any question more?
And for I have one question for the fourth study about the reliability of the modified RAS score. So what is the gold standard to define the union of the by the radiological union?
Okay.
What is the gold standard that you use?
I use the clinicals and radiographic finding combined together and review with their authors to agreement together that defines this one is pretty sure for union. This is gold standard in my study.
So the radiographic union, you use the radiograph or you use the CT scan
Not
to
only
define?
radiograph and clinical findings for medical charts.
Thank you for your answer. For the last presentations about the atypical femoral fracture using the demineralized bone matrix. Any question from the floor?
I have one question. In your piece, in your research, you control the alignment of both group because of not only the DBM. I think for the atypical fracture, the alignment after fixation is quite the main problem. So you control all. It's different between two group. The alignment.
It is some limitation. Another limitation is studied that we not assess the postoperative alignment, but we just partially controlled by the all of the patient was undergone the surgery by the traumatologist doctor in Grand Maternity Hospital.
So, but you got the pretty good result that you can got the union within 5 months, like 14 weeks.
Yes.
So, because the average of the atypical femoral fracture usually healed like quite slowly than usual bone or normal bone. And did you have any difference between the durations or of the bisphosphonate used on each patient? Did you find any effect of the duration of the bisphosphonate use that compromised the healing?
I tried to analyze between two groups, the bisphosphonate and no bisphosphonate use, but there are no significant difference I can detect.
Okay, thank you for your answers. So I think the time is running out. So thank you for our presenters and our participants. Thank you for your attention. And please have time to visit the exhibition at the exhibition halls. Thank you.
Okay, thank you so much. Bye.